Hi, and welcome to Lock Haven's A Senior Moment. I'm Mary Beth Truitt. I'm the marketing director here at Lock Haven. Making a decision, especially a quick decision, can sometimes be just daunting for after hospital stay. What are we going to do? Where are we going to go? Today, the purpose of this program is to help you to have some educated information about what might happen after a hospital stay. And with me today to help decipher all that and to make sense of everything that I just said is Pat Stahl. She is my first guest, actually. Pat is Lock Haven's MDS and Therapy Service Coordinator. And welcome, Pat.
Well, thank you, Mary Beth. I hope I can shed some light on some of the topics that we have today.
I think that you can, because you deal a lot with this in your role here at Lock Haven. So tell us, as MDS and Therapy Service Coordinator, what do you do on a daily basis?
Well, what I do on a daily basis, along with two other staff members, Lee Apel and Chris Rickenberg, is to organize and schedule the forms and the paperwork that has to occur when someone lives in a nursing home. The paperwork is, quite lengthy, and it has to be very timely. So we do have that. The building designated. We have different places in the building that we take care of, and our director of nursing had designated those for us. So we do try to keep that organized and on time in keeping state and federal guidelines the way we should.
Great. Pat, I think one of the biggest misconceptions that I hear, if someone especially has been in the hospital and they need possibly to come to any skilled facility. When we're talking here, we're not talking about just Lock Haven. We have a large viewing area. There are many skilled facilities in that area. But the biggest misconception I hear is, well, I have Medicaid or I have Medicare, and can I come for an after hospital stay? So let's define the difference between Medicaid, Medicare, and help us.
Okay, well, Medicaid is a state-funded program that allows for monies for people that have a limited amount of resource, actually down to $999.99 actually, before they can make application to the state for this program to help them meet their needs. Medicare, on the other hand, is a federally funded program that when you become 65 years old, which I will be soon, you would apply during your open window period for that service, and then that would be more for short term should you be in the hospital, and when you come to the nursing facility, that will help with your expenses.
Okay, so just to clarify, if they're coming for a short-term stay, it is Medicare that we're talking about.
If they have had that 3-night stay in a hospital setting and have also been admitted to acute care. We have had some instances where they have just been on observation, or maybe they have just visited the emergency room, and that will not suffice for using their Medicare. They have to have, and it's counted from the midnight hour, so their head has to be on the pillow at the hospital at midnight, and then to count 3 consecutive days before they meet that rule.
I've got a scenario here, and we're going to talk about some other qualifying things. The 3-night stay is definitely a biggie, but here's the scenario. A person had an unexpected stay at the hospital, and just a few days after they were admitted, they are visited by a discharge planner or a social worker who tells them that they need to make a decision about after hospital care. They are really afraid to go it alone at home or to have a family member to help them at home. I want to let our viewers know that they do have options at a skilled care facility for their recovery. So tell us again, we started down that path with three-night.
Yes, we did. We have to meet that first, then this is how the scenario would play out here. Social service would be contacted with a referral from the hospital. That referral is looked at then by our outreach coordinator and determined if we can meet the need of that person. When the person has been accepted into the facility, the first place they'll go is social service, and they will discuss, and they will also know the method of payment by the time the person has come, or even before they've come, they've determined how payment will be made. And should it be Medicare, then we will contact therapy department. They will have evaluations in just the first day or two to see if the need of therapy exists, to take care of their needs. And so then we also come together twice a week on Mondays and Wednesdays and have what we call therapy conference to see that the people are not, they're still progressing. They're not plateaued. They're not, they have to show that they are improving, and that if therapy is their qualifier, you have to have a qualifier.
Right.
And that could be IV therapy. It could be daily dressing changes. It could be, different things, but it is limited of what are considered to be qualifiers. So once that qualifier has been met and that three-night stay has been met, then they can continue on with a possibility of receiving up to 100 days, but we meet twice a week to determine that. Once they have reached the plateau, their therapy may come out, and then they will be taken off of Medicare Part A.
Okay. What is the average length of a Medicare stay, Pat, or a therapeutic stay? Our biggest goal that we want viewers to know is that people really do go home.
Yes, they do.
I mean, they come for therapeutic stays, and then a good majority of them, unless they choose to stay, do return to their home.
They do.
And so what is that average short-term stay? How long?
I would think it would be anywhere from 2 to 3 weeks, probably. And then, discussions are made, not just at the last minute before it's time to maybe return home, but with these meetings and with correspondence with social service, keeping the residents informed of what's coming next, because it's hard to just know at the last minute and get things prepared at home when you're returning there. So we try to continually let them know what's going on and how much longer it may be, and so they can plan toward that end.
And Medicare pays for how many days as far as a stay in a skilled facility?
Medicare would pay for day 1 through 20 at 100%. On day 21, if they have coinsurance, if they have the Medicaid, if they even want to pay a $157.50 private pay, actually those methods of payment become primary on day 21, and Medicare then becomes secondary.
I see.
Then it will continue on for as long as they need it and they qualify.
Okay. Pat, if someone, our main focus has been a little bit on a sudden illness or a sudden surgery, a sudden hospital stay. But for those who have a surgery, or we've got a hip replacement coming up, a knee, whatever the case may be, should they go ahead and make arrangements at their skilled facility? Should they contact them, say, this is my plan of action?
If it's planned and they know this is going to occur, I can't see why it wouldn't be a good idea to go ahead and make arrangements and let their plan and their wishes be known, so that we can start orchestrating all of this
Okay.
that's going to happen.
And they
for
would
them.
probably get a hold of social service
Yes, that would
department
be
when they
right.
do that. Whenever
Yes.
you contact the social service department,
Mm-hmm.
they can take care of things. One of the things that I've seen, and we're going to be speaking with our program director with our therapy services for rehab care in a little bit. We'll probably get a little bit more into this. But one of the things that I see is recovery time for a person who has, say, had, again, that hip replacement, a knee replacement, to come from the hospital where they've had therapeutic stay to come to a skilled nursing facility where there is therapy services that are going to continue that therapy plan And I would just have to think that the recovery time, it seems, this is only me, an educate, that the recovery time would be better because you know, you're not at home, you're not having to get in a car to drive somewhere.
Right.
Is there, what are your thoughts, Pat?
Well, my thought is that a lot of people don't want to be a burden to another loved one, whether it be a spouse or a neighbor, a friend, you know, and to know that they could be cared for in a safe and secure and loving environment for their recovery would mean the world, you know, really. So that is our mission here, to provide the best care that we possibly can. And each case is individual, so we want to look at those things individually to be able to meet those needs the best of our ability.
Great.
Another thought I had, Mary Beth, is that people may not understand also that if they choose to go home after that 3-night stay in the hospital, instead of coming to a long-term care facility, that they have 30 days in which, if they feel like once they get home they're just not managing real well, maybe it's a little frightening, you know, if they feel unbalanced and just not able to care for themselves as they thought they were going to be able to, that they can still come to the nursing home and use their Medicare here.
That's great information. Thanks, Pat. Now I'm in our therapy department room here at Lock Haven, and with me is Tiffany Blankenship, who is the program manager for Rehab Care. Rehab Care is the therapy service that we use here at Lock Haven for all of our therapy, physical, occupational, speech. Is that right, Tiffany?
Yes, that's right.
All right. Well, welcome. I'm going to have Tiffany help us kind of discern a little bit of what Pat said in our earlier segment. She told us about Medicare, told us about how to get here. Now we're going to talk about what is going to happen once you do get here. So, Tiffany, tell us about Rehab Care first of all. Just a little history, not a whole lot, but just a little bit.
Well, Rehab Care was actually started in 1982. We've been in this business for 33 years. We have therapists all across the nation. We are actually part of a bigger company, which is called Kindred Healthcare, and we share therapists with a lot of different places. So
Yeah,
we range from hospitals to outpatient to long-term care.
I might be totally wrong on this, but did I read before that, do you really focus on senior care though? Is that
Yes,
correct?
we do. Our specialty is the long-term care elderly population.
Okay.
We do outpatients and hospitals in different areas. It's not as common around this area.
Right, okay. And so as program director here at Lock Haven, what is your role? What do you do?
My job is more of a supervisory role and also a mediator between the facility and Rehab Care itself. I make sure that our therapists are in on time, make sure that they have the patients that they're supposed to see for the day, and make sure the flow of the workday goes well. But then I also help with the facility and anything that the facility would like to be done, whether it's talking to patients' families, being part of the care plan team.
Right.
I'll take part in all that.
Yeah, you're always at those therapy conferences that when I walk by. Tiffany, I kind of mentioned, tell us a little bit more about the services that you do, the types of therapy that you do offer
Well, we
here.
do offer all 3 disciplines, which is physical, occupational, and speech therapy. Each discipline has its own unique characteristics. So physical therapy develops more of the musculoskeletal and neurological symptoms. We work on walking, being able to get up and down out of a chair, or things like climbing stairs or going out in the community. Our occupational therapists work more on activities of daily living, which that includes things like dressing every day, brushing your hair, even getting out of bed to get dressed in the morning, getting your clothes out of the closet. Simple things we do every day that we just don't think about. Right. And then we have our speech therapists. And our speech therapists are often forgotten, but they are one of our most important aspects. For our stroke patients, they're a pivotal part of being able to speak again, being able to eat by yourself again, things that we take for granted. But they also help with mental and cognitive therapy and swallowing issues.
Yeah, there is so much involved in a person unless you've had someone in your family or yourself that suffered a stroke, like in the speech and occupational, I mean, when you're talking about adding again and numbers again and things like that, that we do take for granted that can be very much impaired if you've had a stroke.
Absolutely. We do, things like balancing your checkbook. We take that for granted. We do it every day. We get our checkbook out, we pay for groceries at the grocery store. But when you've had a stroke or when you've had an illness of some sort that affects that, we don't think about how difficult that can become.
Right.
And as therapists, we have a lot of patience for those people because we realize it's a struggle to do the basic things.
So Tiffany, take us through kind of a plan of action. A person has come here, they've had either a stroke, they've been in the hospital for some reason, whether it's a surgery. Kind of take us a plan of action. What happens here with that resident from kind of start to finish?
Okay, the process can be kind of daunting. It is actually a very simple process, though. Initially, when a patient comes in, if they come in after surgery or after a stroke or an illness, then usually if they do not have orders, we'll ask for therapy orders and make sure it's okay with their doctor first. It's very important that the doctor agrees with our plan of care because we do not want to put the patient in harm's way. So once we have that, then you will talk to one of our therapists. So sometimes you have one discipline, so maybe just physical therapy. Sometimes it's all three disciplines. And each therapist comes in and talks to them directly. And we establish a very personable, very customized plan of care. As we all know, no one is the same. We're all very unique. And so one cookie cutter plan of care should not be what we do. And so we talk to the patients, and when we're talking to people, we keep in mind, what are their goals? What do they feel like they're capable of doing? What do they want to be able to do when they go home? And we include all that. Sometimes it's a matter of, they say, I'm coming in for 2 weeks, and I want to go home after that.
Right.
So we want to make sure that our plan establishes that. And then the therapy process begins. And then we see them sometimes 3 days a week, sometimes 5 days a week. We've even had some that are 7 days a week, depending on their goals.
Right. So just to kind of reiterate, though, if they've been on a therapy program at the hospital, do you coordinate with the hospital to continue, or with the doctor? Is that correct?
Yes,
To
we will
continue?
always check to see if they've had therapy at the hospital, and we don't necessarily continue their plan of care because in the hospital everything's very in acute stage, so they're usually in more pain. Things are more difficult in the hospital. So when they come here, our goal is to plan out their care so that we continue progressing them forward.
Right.
And our plan's not going to be the same because now the pain's starting to reside, so we can do more. And of course, we're wanting them to do more so we can get them home faster.
Right. Let's talk a little bit about home evaluations, because that is a very big part. You touched on that. Tell us what you do. A person says, I do want to go home in 2-3 weeks. And, I'm really worried because I've got steps right into my home. I really want to cook again. I want to be able to do the laundry. Tell us about those things.
Well, those are all, of course, things we try to address in our initial plan. And so we're working on those throughout the therapy stay. And so if the patient cooks 3 meals a day, we'll make sure that they do cooking while they're here. The home assessment is kind of our way of taking the patient to their actual home. Because no matter how hard we try, we cannot mimic exactly the patient's home. So we take them home for a couple hours, usually is all it takes, and we'll take them through the things that they do every day, such as, walking in their front door. We don't think about that, but sometimes that 2 steps that was easy before is difficult now. So we work on that. Then we'll go inside and we do things like getting in and out of their own bed. Getting clothes out of their closet, stepping in and out of their own tub. Things that we do on a daily basis, but it becomes more difficult after you've had a surgery. Right. And so our goal in a home assessment is to make sure that they can do those things. And then if they can't, that gives us the ability to come back and say, okay, we're going to spend 1 more week and work on these things. So that way when you go home, it is easier. And this isn't as a difficult process. We try to make that transition from here to home as smooth as possible.
That's great. You have got to create some really strong bonds with the residents you're working with. And is it right that they pretty much have the same therapist that they work with?
Right.
Is that right?
We do one-on-one therapy. It's more personable that way, and also our outcomes seem to be a lot better when we can provide that one-on-one therapy. The therapists get to know the patients, and we're not talking just about whether they can kick their leg or whether they can walk down the hallway. We're talking about, we know their family members, they tell us about their lives, they tell us what they did, and that establishes a trust. And with therapy, if anyone has ever done it, they know that therapists ask you to do things that are outside your comfort zone. And so that level of trust really has to be there for us to be able to challenge these patients so that they can get better.
Yeah, that is very true. You know, there is a big difference between a planned hospital stay and an unexpected, illness. They're here, they might be kind of down. Let's talk about that just a little bit.
Okay. Well, in a hospital stay that's expected, the patient comes in, or the resident comes in, they know what they're expecting to happen. They know it's going to be hard work, they know there's going to be pain, and they know that if they work at it, they're going to get back home. It's pretty simple. For someone that has an unexplained illness, or they're not expecting it, such as a car accident or a stroke, it can be very much more difficult. They often have depression, anxiety, a higher level of fear when it comes to doing some of the things such as just standing up. And so as therapists, we take the time to sit back and listen to the patient. A lot of times they just need someone to talk to, and they need to tell you that in the middle of the session, we give them that opportunity to say, I'm scared. And that's okay. There's nothing wrong with that. And we try to help them through that by encouraging them that, people have been through this before. It is okay. We can get through this, and encourage them to keep going. Every step forward is progress. And even if we only gained 2 steps today, that is 2 steps closer to the goal.
Awesome. Tiffany, how often is therapy offered here at Lock Haven?
At Lock Haven, we offer it 365 days a year. Now, that doesn't mean that you have to have it 365 days a year.
Christmas?
But it is offered, and we do have therapists in the building. And so if you come in for a short stay and you're only going to be here 14 days and you want to be seen 14 days, that's what we'll do. And if your plan is to go home but you're not really sure when and you don't want to be pushed that hard, then it's okay to not have that much therapy that quickly.
Okay. All right. I think we covered almost everything. Okay. Anything else that you can think of, Tiffany, before we go?
Nope, I don't think so.
Well, we invite our viewers, if you ever have any questions, if you ever want to stop by here at Lock Haven, give Tiffany a call, just stop in and see us. But wherever you are, whatever long-term care facility that you are considering or looking at, just know that there are options available for you, that you do have the big possibility of rehab and then returning home. That's the main thing that we want you to know. Have a great day, and we will see you the next time we have a senior moment.